Okay, Dr. Aital, you can introduce Dr. Shashiraj Shetty.
So, good afternoon to all. I welcome Dr. Shashiraj Shetty, Professor and Head of the Department, Srinivas Medical College. A brief CV of him is displayed. He has done his MBBS from KMC Hubli and MS from KMC Manipal in 1993. He has worked as a professor at MGM Medical College, Mumbai, then professor at U Medical College, professor and head at Tarna Medical College, and replacement surgeon at Fortis Hospital, Mumbai, and also worked as joint replacement surgeon at Reliance Hospital, Mumbai. So he is with us today. He will be talking about biomechanics of hip and its application. Being a specialist in joint replacement, I'm sure he's going to offer a lot of tips and tricks and the biomechanics of the hip, which will be useful for the postgraduate students. I welcome Dr. Shashiraj. Welcome you, sir. Please.
Hello. Thank you, Dr. Aital.
Thank you. Yeah.
Let me share the screen now. Am I audible and visible to everyone?
Yes, sir. You're audible and visible, sir.
Let me start then. I thank onset to Karnataka Orthopedic Association as well as I am not the HOD. And today's topic about biomechanics. It is like a grammar in English language. It is very difficult, but once we understand, it's very easy. Considering what I was knowing about biomechanics when I was a PG, I tried to simplify it and I'll give the speech. Biomechanics of the hip joint is a study of mechanism of in the human body. The term coined by Soviet neurophysician from the ancient Greek word. Mechaniki means mechanics. So I will classify biomechanics of the hip joint into the following headings: kinematics, kinetics, mechanical and anatomical axis, version of the hip, neck shaft angle, determinants of the joint reaction force. And I will talk about biomechanics of the hip replacement, brief history, offset, frictional forces, volume, and linear wear. And also, if I get time, I will briefly run down about the templating of joint hip replacement. Now, coming to biomechanics. Biomechanics is a science concerned with internal and external forces acting on the human body and produced by the good joint is always highly conforming, well lubricated, compliant, stable. Kinematics description of angular and transitional in response to applied forces without concern for the forces and movements acting on the joint. Kinetics refers to a force and movements acting on the joint during the motion. Now we have to know certain things about the mechanical axis and the anatomy. Femur mechanical axis is from head of the femur to the angular notch of the distal femur. Mechanical axis of the lower extremity, center of the femoral head to the center of the ankle joint. Why we should know this? Because when we do the total hip replacement or the TKR, we will follow that 3-degree cut, 4-degree cut by the technician who comes there. So if you know this anatomical axis and mechanical axis, we will know why we are taking that cut. Now coming to the angle of femoral torsion and anteversion. Angle between the transverse axis of head and neck and that of the condylar axis at the lower end of the femur, which is around 12 to 15 degrees in adults, 40 degrees in children. Acetabular version. Long axis of the acetabulum point towards 12 to 20 of anteversion and 45 degrees of inferior inclination. So this is a anteverted acetabulum and this will be the retroverted acetabulum. Now we come to the neck shaft angle. The normal is around 125 to 135 degrees. In children, it will be around 140 degrees. There will be a variation will be there. If it is less than 125 degrees, causes decreased joint reaction force, predisposes to dislocation in children. The causes are congenital, Paget's disease of the bone, post-Perthes deformity, osteomyelitis, and post-traumatic. The treatment will be valgus osteotomy. Likewise, if you come to coxa valga, it is more than 135 degrees, increases the joint reaction force, causes are congenital, rickets, children with cerebral palsy. And also with the valgus hip, the children will tend to walk entoing gait. That is the correction by the nature. Even with the coxa valga, children can have the epiphyseal flipped capital femoral epiphysis in adolescence. Treatment will be physiotherapy, canes, walkers or crutches, osteotomy. Now factors affecting the magnitude and the direction of the compressive forces affecting on the femoral head. One, position of gravity. Second, abductor lear arm, which functions of the neck shaft angle. Third is magnitude of the body weight. So these are the three lever system which is working on the body. First class, second class, and the third class, where the hip comes under the first class. Now we are talking about the center of gravity. Center of gravity is anterior to S2 and it is behind the hip joint. During the cycle, center of the gravity oscillates laterally and vertically, a centimeter rise and fall. Normal gait, symmetry of step length, symmetry of step duration. Any deviation on this leading into limping. Patient with arthritis, stride length decreases, gait speed decreases. Next. Bipedal stance. Lower limb constitutes 2/6, that is 1/6 on each limb, and upper limb and trunk constitutes 4/6 of total body weight. Little muscular forces required to maintain the equilibrium in two-leg stance. Body weight is equally distributed across both hips. Each hip carries 1/3 of the body weight. Single leg stance on the right side. Right lower limb supports the body weight and also left lower limb, that is 5/6 of the body weight. Effective center of gravity shifts to the non-supportive leg, produces downward force to tilt the pelvis. Right abductor must exert downward counterbalancing force with the right hip joint as a fulcrum. Tunnel bug sign. Weakness of the thigh abductors tested by asking patients. The pelvis sags to the opposite side while standing on the affected leg. Use of cane or walking stick. Additional force that keeps the pelvis level in the face of gravity gravity's tendency to adduct the hip during the unilateral stance, decreases the momentum between the center of gravity and the femoral head, reduction in abductor force by 67%. Even at rest, hip is never never unloaded. Normal gait around 2 to 3 body weight, stair climbing 2.3 to 5.5 body weight, accidental stumbling is around 8 times of the body weight, running 10 times of the body weight. Slowing gait decreases the momentum of the body, thus predisposes to backward fall, fracture the hip in elderly. Now we are talking about the joint reaction force. Force generated within the joint in response to the force acting on the joint. Result of need to balance the momentum of the body with pull of hip abductors at greater trochanter to maintain the level of the pelvis. Contributors are muscle forces and the body weight. Joint reaction force is a triple force, can trigonometrically symbolizes in a free body analysis, free body diagram. Here, W is gravitational force, weight of the body minus weight of the ipsilateral extremity, that is 5/6 of the body weight. M stands for abductor muscle force. R, joint reaction force, can reach up to 3 to 6 times a body weight. Solving the joint reaction force. Step 1, calculate My. Principle, sum of all the moments equal to 0. In the cases of moments are created by My and W. Equation A into My plus B into W is equal to 0. Assume A as 5 centimeter, B as 12.5 centimeter. This information is given to us. My is 2.5 body weight. Step 2, calculate Ry. Ry is My plus W. Ry is 2.5 plus W. That is, Ry is 3.5 body weight. Calculate the R. R is Ry divided by cos 30 because it makes the 30 degrees of angle. R is 3.5 divided by cos 30, that is reaction force, joint reaction force is 4 times the body weight. Clinical implication of the diseased joint reaction force. Moving the acetabular component medially, inferior and anterior. Long stem process of the femur. Lateralization of the greater trochanter by increasing the offset. Whereas neck shaft angulation causes increased sharing. Factor decreasing the joint reaction force are shifting the body weight over the affected hip head or carrying the load the ipsilateral head. Pathomechanical factors in hip pathologies are increase the body weight, momentum, decrease in the abductor force, decrease in the abductor. Management of painful hip disorders. Aim to reduce the joint reaction force. The joint reaction force is equal to body weight plus abductor force. Strategies to reduce the joint reaction force by decreasing the body weight or the momentum or help the abductor force or momentum. Increasing the abductor lever arm, increase the offset, do a osteotomy or greater trochanter lateral transfer. Aims of the total replacement, relieve the pain, improve the function. Application of biomechanics to total hip arthroplasty. Here we should know about the joint center, neck angle, offset, lever arms, range of motion until the impingement. So I would like to briefly talk about Sir John Charley. He is a father of hip replacement surgery. His surgery is called as the surgery of the century because hip replacement, he studies led into the low friction arthroplasty concept. So low friction arthroplasty is medialization of the cup. Medialization of cup in the sense center of rotation, lateralization of the trochanter, abductors, use of cement first time in THR, and proximal collar prevent the sinking. Femoral offset is the distance from center of the rotation of the femoral head to the line bisecting the long axis of the femur. True angle of motion of process is influenced by the orientation of the components, muscular and soft tissue situation, as well as patient characteristics. Offset, medial and vertical, version, femoral leg, reconstruction of determines principle to decrease the joint reaction force. Centralization of the femoral head by deepening the acetabulum decreases the bone lever arm. Increasing the neck length and lateral reattachment of the trochanter lengthens the abductor lever arm. Size of the taper influences the stability of affecting head-neck ratio. Larger the head-neck ratio increases the range of motion with lesser chances of impingement. Narrow neck tapers are also stable. Decreased wear of the implants. 4 major factors which constitutes the stability are component design, component position, soft tissue tensioning, soft tissue function. The different head size, Chamley used 22.225, but nowadays we use range from 28 to 36 millimeters, preferably 32. Increase of 13 degrees in technical range and the jump distance. Advantage of larger head, increase the range of movement, increase the jump distance. Disadvantage of the larger heads, higher separation of the joint, higher friction, increased joint relocation, requires better fixation, loosening of the cup. What is jump distance? Distance head has to jump before leaving the cup amounts in hemispherical cups to 50% of the head diameter. Geometry of the stem, thinner tapers impinge with cup, thinner tapers less torque to loosen the head. Restoration of the offset, neck length tensioning, neurological axis of the function. Permanent change of the hip joint of the soft tissue, envelope and muscles. Alteration in the joint mechanics, elasticity, lubrication, load transmission, efficacy and stability. Lubrication of the hip joint. Elasto-hydrodynamic lubrication, synovial fluid. Exactly, it will get trapped. So the synovial fluid is a very good source of load bearing. It increases the capacity of the surfaces. Prosthetic joint lubricated by different mechanism, either by boundary lubrication, fluid film lubrication, or a mixed type. What is pincer impingement? Involves excessive coverage of the femoral head by the acetabulum. The head is small, femoral acetabular cup is big, then you will have a pincer impingement. Impingement. The femoral head is not round and cannot rotate smoothly inside the acetabulum, causes cam impingement. Now, I just briefly wanted to tell you about the templating, process of anticipating the size, position of the implant prior to the surgery. Importance is allow the surgeon to anticipate potential difficulties to reproduce hip biomechanics, minimize the limb length inequality. Accuracy is 50 to 98%, plus or minus size related to experience and the practice. Steps. In AP view, draw horizontal line connecting the ischial tuberosity. The X-ray should be adequate. The adequate AP X-ray, there are some norms. Next. Acetabulum, place the appropriately sized acetabular template with roughly 40 degrees. Mark the center of rotation of the acetabular component. Templating the femur. Choose the appropriate size femoral implants to fill the medullary canal. Insertional depth is determined by optimize the limb length inequality. Restore the offset. Match the center, check for the length discrepancy. Total hip components, femoral components, head neck system, acetabular components. Cemented stems, most favor cobalt chromium alloys. Cementless stems with porous surface. Acetabular component, cemented and uncemented. Acetabular augmentation is by long posterior wall, elevated posterior wall, and constrained liners. Cemented acetabulum components. Cementless acetabular. Plastic, metal, and ceramic. Head, metal, cup. Head can be metal or ceramic. Cup can be plastic or metal or ceramic. Head cup, material cup. Hard on hard, metal on metal or ceramic on ceramic. Hard and soft, metal on poly or ceramic on poly. Soft and soft, normal joint. Volume, linear wear. Sliding distance depends on the radius of the head. Volumetric wear depends on the sliding distance. Linear wear is inversely proportional to the radius and sliding distance. Wear, primary wear mechanism, addition, bonding of surfaces when they are pressed together under load results in material being pulled away from one or more surfaces, usually the weaker one. Abrasive wear, harder surface cut through the flows through the softer surface, resulting in removal of the material. Fatigue wear, when the material fails after certain number of loading cycles with release of material from the cup, softer side. Wear modes, mode 1 from the motion of two primary bearing surfaces, one against each other as intended. 2, condition of primary bearing surfaces moving against the secondary surface, which is not intended. Mode 3, condition of primary surfaces moving against each other, but the third body particles interposed. It is called as third body wear. 4, 2 secondary, non-primary surfaces against each other. Ultra high molecular weight polyethylene, if the head moves consistently in one direction, that is called linear motion, its molecules reorient and harden in that direction. So it is called as strain hardening. If the wear tracks multidirectional, strain hardening, wear reduction, wear track in the hip. Wear track in the hip is elliptic and eccentric. Wear rate is proportional to the amount of cross shear. Femoral head undergoes microseparation in the acetabulum during the gait cycle. Similar microseparation also occur in unconstrained total replacement. Metal on metal or ceramic on ceramic, less vulnerable for microseparation. Biomechanics of the hip joint is complex. There is a need for understanding the forces acting on the hip joint, both during the health and during the disease. I would like to put something more into your brains, because nowadays hip joint, as it's concerned, biomechanics is not only the acetabulo-femoral component. It also involves the sacroiliac joint as well as the lumbosacral complex. Because nowadays, when we do the total hip, for the cup placement, we will take the lateral X-ray of the lumbosacral spine sitting and standing. When the patient having a lumbosacral spine free, or it is in kyphus or extra lordosis, depending upon that, we place the cup. So, like shoulder joint movement is combined of humeroglenoid, acromioclavicular, sternoclavicular, scapulothoracic. Likewise, hip joint also should be considered with sacroiliac joint movement and lumbosacral joint movement. Thank you very much.
Thank you, sir. It was a very informative talk. Any questions? The delegates can put their questions in the chat box or question and answer. Any questions? There are no questions. Dr. Shyam?
Either they have understood everything and that is everything has gone, sir.
Either they have understood everything, which is the most likely possibility, or not understood. Good afternoon, Channakeshwara sir.
Dr. Chanakeshwar Rao was my senior at Manipal. He's still the same.
Shashiraj, after a long time I am seeing you.
Not changed, sir. So many
Oh
years.
my goodness. Thank you for the compliment. You are also the same, maybe with a small beard now.
Okay.
Beard with beard. Bearded Shashiraj.
I was with the Channakeshwara sir for a brief period at Surya.
In Sulya, 2001.
2001.
2002.
Yes, 2001.
Expecting any questions?
I think we only should ask questions.
If nobody is coming forward with the questions, then we should have the access to ask them questions.
That's what I was also thinking.
Did we understand something?
No, but let me see the participants. There are 32 participants, 26 attendees. That's good.
Very good, very good.
So, anybody from the participants group want to ask them question? Especially, both the topics are very important topics. Channakeshwara sir, I missed your talk. But can I ask you a question?
Yes.
How often you see the peroneal spastic flat foot in your practice?
Not very common, but at least maybe one case in 3 months or 4 months.
And
in
how
my
much
practice.
of them will be associated with the accessory navicular bone?
At least more than 50% of them. Accessory navicular.
Yes. Okay. For the benefit of the attendees, can I ask one question to Dr. Shashiraj?
Yes.
Yeah. So originally, when there was this concept of medialization of the acetabular cup, but now it is only going up. Can you give your inputs on that based on the biomechanics of it?
Sir, usually this low frequency total hip replacement, which is coined by Charlie, it has been very, very good. It was doing very well. Still, the follow-up cases of Charlie's hips are still there. But over the period of time, our understanding of mechanism, biomechanics has improved. We found that like taking the hip center, either medially, superiorly, or inferiorly, it is going to become a more difficult task. Wear and tear will be more and more. So nowadays we prefer anatomical hip center. That is the original hip center. There are different methods. One method I told you, the template. There are different systems how to calculate the original anatomical hip center, which is supposed to be the best for as far as the biomechanics is concerned. So the now term of medialization is gone. So nowadays we prefer more of an anatomical hip center, and it could be inside the cup, at the edge of the cup, can be outside the cup. That we can arrange depending upon offset, what offset we want and what is the limb length we want. But all the papers say the hip centers, anatomical hip centers do much better. That is why when we do a replacement for dysplastic hips, where the centers are established totally lost, we'll do a supragoneric osteotomy. Either we bring the center down or we'll go for the higher hip center. This will not last long as the other anatomical hip centers.
Thank you. If you are not getting any questions, I think it's better we close the program. So I would like to thank both the speakers for sparing their time and being with us here, teaching the postgraduate students. Thank you, Dr. Chanakeshwara sir, and
Thank you.
I would
Thank you very
also
much,
like to. I would also like to thank Dr. Mallikarjun sir, President of KOA, and Dr. Roshan, Secretary of KOA, for giving us this opportunity. I would also like to thank Microlabs who have provided the support for this program, and I also thank Shamsundar, my friend and co-moderator, conducting the program. Thank you all.
Thank you very much. Thank you very much.
Thank you very much.
Thank you.
Thank you, one and all.